All right, well, welcome. I want to say welcome to the Humana team. Thanks so much for joining and having a great representation for the call. So obviously we won't go through introductions, but Kimberly Myrick is our child health program analyst, and she's going to go over a very thorough overview of the EPSDT benefit. So I'm not sure if she wants you guys to hold your questions to the end. I'm thinking so she can get through most of her material and leave time for you guys to have questions at the end. And before I turn it over to Kimberly, I'm Carla Callahan, Assistant Division Director for Healthcare Services, and we are happy to have so many people here and happy to continue to support you guys with implementation. So I'll turn it over to Kimberly.
Thank you, Carla. Hello, everybody. Thank you for joining me today. People are still coming in, but that's okay. I don't want anybody to miss anything. However, just a quick introduction. My name is Kimberly Myrick, and I am, as Carla said, the Child Health Program Analyst. And so we will begin our presentation. I just want to make sure that everybody can see my screen. Okay. So, well, welcome again. I will be going over the EPSDT benefit. We spoke with Dr. Mattingly, who was graciously let me know some of the concerns and the issues that you guys wanted to talk about. So we will do a brief presentation about the EPSDT benefit. And then we will go over some basics, some covered services, the medical necessity review, and some of the deliverables. And then, as Carla said, please hold your questions until the end. I might answer some of your questions throughout the presentation, but we want to definitely get through each of the slides. So, okay. And we're going to just start with the basic overview. The early and periodic screening, diagnostic, and treatment benefit, referred to as EPSDT, is a federally mandated Medicaid benefit authorized under the Social Security Act. EPSDT provides comprehensive preventive healthcare services, diagnostic services, and medically necessary services for children under the age of 21 who are enrolled in Medicaid. This benefit is key to ensuring that we identify health concerns as early as possible. We want to ensure that treatment is provided before problems become more complex, and to medically justify that services are provided to treat or correct identified problems. The goal is to ensure individual eligible children get the care that they need when they need it at the most appropriate setting. And again, many of you might know the benefit, but definitely this overview can kind of get you more familiar with what we do. Excuse me. All right, so EPSDT is a benefit. It's not a program or a waiver. I do manage the EPSDT mailbox, which I'll give you that information at the end, but a lot of times we get approached as it being a program. How can I get into the EPSDT program? It's a benefit. Children enrolled in Medicaid are entitled to the EPSDT benefit, and this includes youth enrolled in our DMAS home and community-based waiver programs. Additionally, children in FAMUS may access the EPSDT services until they're assigned to an MCO, at which point their coverage shifts to the FAMUS benefit. So that does not include the full protections of the EPSDT benefit. So all children do have access to the screening portion, the well-child visit portion, but FAMUS MCO kids do not have access to the full benefit. Let's see, all children, again, under 21 enrolled in Medicaid are entitled to it automatically without needing to apply. So there's no application process. I get those questions a lot as well. And, again, it's a benefit, so there's no application process to access the benefit. Services covered under the benefit are not limited to services listed in the Virginia State Plan. However, the services must be allowed under federal Medicaid law of the Social Security Act. So if a service is medically necessary under EPSDT, it must be covered even if not part of the regular Medicaid state plan. All right, and EPSDT requires screenings at regular intervals, and we call that periodic screenings, and when medically indicated between intervals called interperiodic screenings. And these particular screenings help identify health and developmental issues as soon as possible, as early as possible, so that appropriate treatment can begin right away. And these are just a few of our screenings, the comprehensive health and developmental screenings, your physical exams, vision and hearing screenings, and many of the other ones, immunizations, and a lot of those are caught during that well-child visit. Per CMS, any qualified provider operating within the scope of their practice can provide an EPSDT screening service for individuals under 21. A screening conducted by a qualified provider who is not a Medicaid provider can still be the basis for EPSDT coverage for the follow-up diagnostic services and treatment by a qualified Medicaid provider. So, you do not have to be Medicaid enrolled in order to provide those initial screenings for a member. Okay, and this is just an overview of some of our diagnostic and treatment services. A lot of these, some of the main ones that that I come across that I see getting utilized are the hospital services, dental, mental health, physical therapy, vision, durable medical equipment, assistive technology, private duty nursing, and personal care are a lot of the services that get accessed either through the MCO or through Medicaid. EPSDT covers all medically necessary services that are included in any of the categories allowed under federal Medicaid law. Again, even if not in the state plan. You'll probably hear me kind of repeat things because it's just stuff that sticks out that kind of constantly comes across, and also trying to address some of Dr. Mattingly's questions. So yeah, this is transportation services and language access and culturally appropriate services such as an interpreter and translation services are also under the benefit. So sometimes people might be unaware of that, but that's also covered. And I also wanted to bring up, I also deal with the early intervention population, which deals with children 0 to 3. So sometimes that does cross over into EPSDT as well, because we're talking about services being accessed for that population as well. All right, so this is our periodicity schedule, which many of you know is a schedule of screenings and assessments recommended at each well-child visit from infancy through adolescence. These screenings must be provided at intervals that meet reasonable standards of medical practice. This slide just reiterates that EPSDT ensures timely access to both preventive and medically necessary services. Virginia refers to the American Academy of Pediatrics Bright Futures periodicity schedule. And then there's a dental periodicity schedule, and their guidelines are from the American Academy of Pediatric Dentistry. And next, we'll kind of go through the medical necessity review criteria. A lot of times there's a lot of questions with this. So it's such a huge benefit that we can't answer all questions because this is really tailored to individual members' needs, but we can definitely go over the process, the medical necessity review process, to kind of try to make things a little more clear. Okay. So because EPSDT is focused on the needs of children, federal law stipulates a different set of rules needed to determine if a service is necessary and therefore coverable under Medicaid. The benefit, EPSDT ensures that the service provided can correct or ameliorate a condition, and ameliorate meaning improve or make more tolerable. You'll see that all the time in our language, of course. And sometimes you kind of get, maybe issues of the member understanding what that means. We do provide like readability level information in our outreach guidance. So a lot of times you can just kind of put that in parentheses, make more tolerable, to let them know what that means. Ameliorate, it's a key term used in federal law defining the EPSDT benefit. So again, you can always kind of parenthesize it. I think that was one of the concerns as well, if you are doing a lot of member-facing materials. Right? The EPSDT standard for medical necessity is different from the adult Medicaid standard. It considers a child's long-term needs, including nutritional, social, and developmental needs, not just traditional medical issues. When a screening shows a need for further evaluation, the diagnostic evaluation must occur within 60 days or sooner if medically necessary. If a service can improve or reduce the impact of a condition, it may be considered medically necessary under EPSDT. And it does need to be determined on a case-by-case individual basis, and consider the EPSDT criteria. Again, you'll have a lot of families and members saying that they qualify for the service, but this person was able to receive, and so again, it's very much an individual basis, case by case basis. Services for Medicaid children that do not meet the plan's general coverage criteria must receive an individualized secondary review by a licensed physician with experience in treating the member's condition or disease, and that ensures the EPSDT provision has been considered. This is something we really, of course, we want MCOs to know and be able to show. DMAS and MCOs may require prior authorizations in order to safeguard against unnecessary use of service, but prior authorization process must not delay access to the medically necessary service. And this is outlined, and I'll share this with you guys after, but this is outlined in several sections of our contract, as well as our provision for EPSDT service authorization. So I can provide that. I think Dr. Madeline wanted some extra information on where to find those things. So I can point that out to you as well. Okay. All right, so again, for members under the age of 21 years who do not meet the standard criteria upon initial assessment, a second individualized review by a licensed physician with experience in treating the member's condition or disease and ensures the EPSDT coverage provision has been considered. The secondary review is conducted to determine if a member needs medical necessary treatment under the EPSDT benefit to correct or ameliorate defects and physical and mental illnesses and conditions, including SUD, discovered by the screening. I get a question a lot about if the secondary review can be conducted by the same reviewer using the correct or ameliorate criteria. Yes, that is a question I think we get. Pretty much so because there's two steps involved in reviewing a request for service, the result is a single decision. The second step is the individualized review. And so both steps can be accomplished by the same reviewer, provided the reviewer has that experience again to conduct the second step. Okay. Yes, and so, I think sometimes you need clarification with that, MCOs. And there are MCOs that do sometimes use the same reviewer and some feel it necessary to use a secondary reviewer, but you are allowed to, that second step is able to be conducted by the same reviewer. All right, and excuse me, the contractor's EPSDT review process, the policy and procedures must ensure that any denial notice, including for non-covered, out-of-network, and/or experimental services, explains that EPSDT criteria was applied and cites the reason the requested service was determined to not meet EPSDT criteria. The notice must, I'm sorry, can you guys mute your lines? I heard some feedback. The notice must reflect that a secondary review was performed using the EPSDT correct or ameliorate standard, and the notice must comply with federal and state regulatory requirements. We do not have a standard template for a denial letter, but this is what is required to be in the letter. It must include, again, a detailed explanation of the process used to review the request, including references to EPSDT law. If the service is not covered under Section 1905A of the Social Security Act, or is covered but not considered medically necessary, the notice must clearly explain why. It should also reference any documentation provided by the treating provider or other medical evidence submitted by the individual. So this is the part where, you know, you're showing the member why they were not eligible for the service. So providing any documentation would be appropriate. And once again, if a service for a member under 21 is denied, that secondary review solidifies the denial. It's not considered a fully denied service until that secondary review has been applied, and they provide that correct or ameliorate standard. Okay, and again, must be conducted by someone with experience treating the child's condition. And so I'm trying to think of anything else I could add to this part, because we do get questions. I want to make sure that you are including, you know, your denials properly, or the letter is including all the information properly. And I believe I'm working with someone else in Humana on the development of the denial letter. So we can further look at that, or I can review some of those recommendations or give recommendations in the future. Okay. And so now we're going to go over the deliverables specifically for EPSDT. We have the EPSDT services report, which I do go over. So EPSDT related deliverables include this report, which pretty much tracks exactly what I just went over. We look to see and make sure MCOs are going through the steps necessary for that full denial. So we track the secondary reviews. We track the denials after those secondary reviews. And also what's required is a referral after. So if a service is denied, we want to make sure that that family is getting access to information that they need to further support since they didn't get the service. So we look at those secondary reviews, the number that were applied that did not meet criteria and were denied, and then again, those referrals after the denial. We just want to make sure that children are getting access to support, regardless if they were denied or approved for that service. Let's see. We also, also for, we look at, in this particular report, it reflects the population captured for our children and youth with special healthcare needs who pretty much access the benefit, right? So we kind of look at your populations to see what you're kind of dealing with. Regardless of the aid category, this report captures info related to applicable services rendered to members all under 21. And this data encompasses all members under 21, regardless of that status. And so we also look at your care coordination efforts as well. And pretty much, you know, who's assigned a care coordinator for all children under 21. So that's what this particular report reviews, and it is the MCO reported data. And so we will probably work together a little bit more over deliverables in the future, if that is something that you're interested in. I believe that is what we can put that together. Okay. So, In terms of guidance, I think Dr. Mattingly also asked like where a lot of this information can be pulled from. Aside from our DMAS provider manual, the EPSDT supplements that goes over your personal care, your nursing guidance, assistive technology, vision, dental. The manual pretty much provides a lot of information regarding that according to the contract requirements. Also, a guide for states is very helpful. And this presentation will be available to you afterwards, so you can kind of access the links from here. State regulations, and again, the contract itself is very helpful, and you can also reach out and I will provide that information as well. So here's a list of some of the contacts. Number one being the EPSDT mailbox. We receive a lot of questions, not necessarily billing questions, or we do receive billing questions, but this particular mailbox is mainly for the policy part or the operations portion of EPSDT. A lot of the questions that we get are clinical in nature, and so we do reach out to our Office of Chief Medical Officer, sometimes for help or guidance with the clinical aspect of EPSDT. We also have an early intervention mailbox, and again, those things do kind of overlap. So our early intervention population ages 0 to 3 encompasses that EPSDT benefit category as well. And a lot of those questions, a lot of questions that I do get from that mailbox are from our early intervention providers. Also MCOs that would like to be connected to maybe a local lead agency or have any questions about our EI or early intervention benefit. The CCC Plus waiver mailbox is used a lot because although EPSDT is the benefit and we go into all portions or all populations, there are things that are specific to CCC Plus or waiver children that can also be incorporated into your question, even if it does have to do with EPSDT. And also questions regarding our assistive technology and environmental modifications can go to this particular link as well for support. And environmental modifications are not under EPSDT. However, there's a lot of questions that go into those types of support or durable medical equipment as well. So this is a good link to access that benefit as well. So we stuck to, again, this, it's not a lot of slides. I didn't want to overwhelm you. I just wanted to stick to the portion of the program that Dr. Mattingly kind of referenced as you guys wanted to know about. So at this time, I would open this up to questions. Again, please use this mailbox, the EPSDT@dmas.virginia.gov mailbox, and that way you can kind of get any information, as well as myself, and I will leave my personal DMAS email as well in the chat for you. So I now would like to, let me go ahead and see if I can exit my portion out. Guess I'll stop sharing. And if you do have a question, please feel free to answer. I do have help kind of monitoring the box. One of the questions is, can you send the slide? I definitely would. And let's see here. Okay, so does anybody have questions? You can come off mute or you can put your questions in the chat. And if there's any questions that I can't answer at this point, please send them or we'll take note of them in the chat and I will provide them responses to Dr. Mattingly to get feedback to you. So are there any questions that you guys have?
Hi, Kimberly, there's a question in the chat for you.
So far, and maybe I'm not seeing it. The question is, can you send the slides? Am I missing something? I think we will send the slides, but is there any other question, Fatima?
Kimberly, thank you very much. I got a quick one here that's come up. Scenario where, let's say a child was admitted to the hospital, the provider never got the service off, The child was discharged from the hospital, so they've already received the services, but the provider didn't get the authorization. Does that need to go through a medical necessity review, or can that be administratively denied? Let's say 2 weeks later, the hospital sends in a request for a retro authorization. I know in some plans do administratively deny that because they didn't do the authorization, but what are your all's takes on that since they've already received the services?
So I don't believe I can answer that particular question. In terms of I think I posed that question to our appeals division because I think you asked that as well. I would have to take that back to them. I'm not comfortable, but I know that if that service has been administered, again, that secondary review process needs to be applied before issuing any type of denial. But in terms of that circumstance, I would like to take that back and get you a more appropriate answer. I think I need a more clarification on that question. So,
yeah, I
in
know
order
I
for him
talked to the
respond.
appeals department, and they kind of said, well, yeah, if they don't follow the contract, that's, and they've gotten the service, but then again, it was sort of muddy. They also said, well, they're going to get back to me, but nobody's gotten back to us.
Can you send me that particular question? Because I think when I went to appeals and asked that, he needed more clarification. So I think what you provided would be
Okay,
beneficial,
cool.
and I can get a direct answer for that.
All right. Well, thank you very much.
This is Dr.
Sure.
Price Stevens. Dr. Madley, I can also look into that on our policy in terms of retro reviews and circumstances such as, if a person comes in unidentifiable or they had the incorrect insurance, and then they say we sent the information but to the wrong insurance. And also, just because if we're talking about EPSDT is, was it medically necessary even though it was not timely? Because typically that is going to end up, going in favor of the member or the hospital once reviewed on appeal. So that those are the caveats. But I also will look to see what we have stated policy on the retro reviews, and if we do those. Thank you.
I know that there's the potential, and we experienced this, Lisa, in the previous thing, that some hospital systems just decide, well, we're not going to even notify you until later on. We're not going to worry about it. And they know that then the medical necessity portion will be okay. But then again, they're not doing their share of getting service authorizations as required.
Yes, I definitely hear you on that one. And we actually have had collaborative discussions, and I think that's something that should be maybe revisited with the hospitals and particularly the NICU providers, and saying that, they only had seconds to make a decision about transfers or, certain treatments. And this is what they were faced with. So I definitely hear you on that one and know that it happens probably more frequently than not. And that would be a good opportunity to have that collaborative engage that collaborative discussions about why those authorizations are not being requested, what barriers they're facing for that.
Thank you.
Thank you, Dr. Stevens. And I think there's a question in the chat from Vicky. Have work groups coming out similar to what we have done in the past for Well Child? And I'm sorry, Vicky, are you referring to, which work groups are you referring to?
Hey Kim, just as we've done like we've done in the past, where we've done but it was just designed to support like a well child visits. So I wasn't sure if this is going to kind of bridge off to like an EPSDT work group, maybe like in collaboration with you guys again, or with other MCOs, or maybe I'm too future forward right now.
Yeah, that's that's not a problem at all. No, I'm open to those kinds of suggestions as a way to offer support. We've recently received some guidance from CMS where to kind of maybe enhance our services under EPSDT and work with MCOs. So we are open to things like that. We want to expand the training for EPSDT as well. So I'm open to that. We're open to that, but we don't have anything set in stone yet. That's not something that we have in place right now. But Yeah, that's a great question, Vicki. And it's good
Thanks,
to see you
Kim.
again. I haven't seen you in a
Yeah,
while.
it's
So
good to
good
talk to
see
you. Yeah, I know. It's good to talk to
Mm.
you as well, too. Sorry.
Thank you. Thank you.
Thank you.
Uh-huh. And do we have any other questions? Again, when you guys do reach out, I want some of those specific questions like Dr. Mattingly, those are definitely something that we can take back because they'll require a lot more research on our end. But yeah, I appreciate all questions. Is there anything related to the presentation that needs clarification?
Can you go back to the slide about it can be the same reviewer as the first reviewer?
Sure.
Can I see that slide again?
Sure. Let me see. Hold on 1 second for you. Yep, this is the slide here. Did you have questions surrounding that, the reviewer, possibly?
I just have never seen it. I mean, it written anywhere that it could be the same reviewer
Mhm.
reviewing. So
Yeah,
I was just confused
Sure.
about that.
Sure. Yeah. So this we can provide for you. It came up as after a review from MCOs before. So I can pull the language for you as to where it came from specifically, but where it's allowed. And Dr. Stevens, do you have any maybe just insight into that? Because I know we discussed about who can review in terms of a licensed physician or what that entails, the type of doctor. Do you have any added insight to that?
Yes, I am, I just want to clarify, and I think that this sounds like it's before the official denial went out. It's right. This is what I'm reading. Like if you know that you have an EPSDT case and you're saying, listen, I think this may not meet before I do that. Let me get a second review. And just say that's different than once you've already denied. And I think that's what our person here, our support person is talking about. Once you've already denied, it should be another person. You don't review your own denial. And then there's already guidelines about whether it's a supervisory, medical director relationship, or it's an outside, community person that you have on retainer, that type of thing. So I think that this, what I read, may be a little bit different for that. So if you are a family practice, internal medicine physician or cardiologist, and which you've been trained, you can review this case. But then this is specific for behavioral health or autism. You would, before making that decision, should get maybe someone who works in your plan who's a pediatric psychiatrist or a psychiatrist to review this case with you to say, hey, I did get someone in scope to make this decision why this is not needed. Does that help a little bit? That's a little bit different than the common denial process. This is kind of before that.
Okay, thank you for the clarification.
Yes.
Yeah, I think Kim and Lisa, I think we need to have that written out a little clearer because I understand what you're saying, Lisa, but if it was like a pediatric neurologist who did the initial review and it was a pediatric neurology case, I would assume that would be what you all are talking about, and that's the same person.
Right. And this is before officially denial, because even if you had an official denial that went out, it still should be another independent person. I don't believe that's what this is speaking to. This is saying before you issue a denial, make sure you've crossed all of your T's and dotted your I's. One, making sure that this has been reviewed by someone this is in scope. If it's you, good, keep going. If you know you're not particularly in scope for this, you may want to grab someone who is. That's how I interpreted what she was trying to reveal here in this slide.
Yeah, I think the plan would love to have a little bit of written clarification so we don't cross any boundaries that are not supposed to be crossed.
Understand that's always good for clarity. Is great, and Kimberly, I can work with you with that. So thank you for pointing that out and asking your question.
Thank you.
Thank you, Dr. Stevens.
I'm sorry, I have a question.
Yes.
And it's around the report that you pulled up.
Mhm.
So when will be like the start date that you want us to look for? Do you want us to look at the authorization date, or do you want to look at the actual denial date?
Oh, for the deliverables?
Yes.
So we're looking for the denial date. So anything that you've done prior, the service was authorized, the denied, the secondary review, and then the denial after that review. So we're looking at those particular cases.
Okay. So the start, and just to have some boundaries of what I'm going to be reporting. So I'm just going to look when the authorization was denied for the month of June, for example,
Mhm.
right?
Mhm.
Okay,
Uh-huh.
perfect.
Yep.
Thank you.
You're welcome. You're welcome. And when the recording will be available. So I will try to get the recording to you probably by no later than next week. No later than next week. I think we'll be able to get it through, but I want to make sure that I get everything, all the questions answered, and uh, anything that I kind of missed. So we will get that to you. Thank you, Janae. Thank you. So we have a few minutes left, but I did want to again I'm sorry, I will get the presentation out to you, but I will send Dr. Mattingly all the information, links, and the contact information. I can send that very quickly. So you have access to me and access to the mailbox. So for now, if you guys think of any other questions, please reach out. And I will put my personal email in the chat. And anything aside for this presentation, please reach out to me, but also your questions in the EPSDT mailbox as well. Dr. Stevens, thank you so much for your clinical expertise and input during this. Certain questions that I feel you definitely have insight on. I appreciate that so much. So I don't want to take up any more of your time. It looks like we're good to go. So please, Dr. Mattingly, feel free to reach out to me and we will get back to you with some of your specific questions. And I really appreciate you guys. Thank you for coming on with us. We're excited to work with you. And again, I work with early intervention and the EPSDT benefits. So if you have questions, please feel free to reach out. And thank you so much for attending.
Okay, thank you very much, Kim.
Thank you.
Thank you. Bye.
Thank you. Bye-bye, Vicki.